Welcome everyone to another video. Um, just a quick introduction. My name is Dr. Salma Motori. I'm a salaried GP in the Northwest area, and today I'm going to talk to you about surviving and thriving in your GP placement. So if you're just about to start your GP placement as an FY2, medical student, or as a GP trainee, this one is definitely for you. So today we're going to talk about a few things. First, we're going to go through your daily schedule. We're going to go through what happens exactly in induction, the dress code expected, the kind of support that you get in a GP placement, and I'm going to take you through how to use one of the computer systems, which is EMIS. There's a few computer systems that we use in GP practices, but EMIS is one of the most common ones, and I'm gonna take you through how exactly to use it. And then we're going to talk about a few common cases that you would encounter in a GP setting. And then at the end, if anyone has any questions, I'm happy to answer them all. So before we start, I'm not sure if you know what a GP surgery looks like. Um, but basically, it's a small building. Sometimes it's like a house. Sometimes it's actually a really big center. But usually it is a building that has a few clinics inside of it, and then the reception area. So it is independent of a hospital. So a GP surgery is not in the hospital. It's completely outside, usually owned or rented by partners. And this is how a typical GP surgery would look like. And this is how a typical GP clinic would look like. In the clinic, you'll be completely on your own. So there isn't a nurse with you, or there isn't someone inside the clinic with you unless you're on an observership or you're a medical student who's observing the GPs. But other than that, you'll be completely on your own. And this is one of the downfalls of GP, I would say. So, how does a typical day-to-day schedule looks like? This is the rota for an 80% GP trainee. And typically what happens is that we have two surgeries. So we have two sessions, the morning session and the afternoon session. Each one of them runs about 2.5 hours. It depends on the surgery that you're in. In the middle, in between them, it's divided into admin, your lunch break, and home visits. Okay, so if you can see here right here on Monday, your morning surgery will start at 9 a.m. We'll finish around 11:30. And then you'll have the time in between, which is your admin work, your visits, your lunch break. Now, at the beginning, when you're starting, you're not going to have much admin, but as you go on, the admin is going to pile up. Now, most of the time, trainees, especially when this is your very first placement and you're starting, we use this admin and visit time in order to discuss cases. So you'll discuss your clinic. And then you'll have your lunch break, and then you'll start your afternoon surgery. And then again, you'll have admin and time to discuss the cases. Now, as you all know, as a GP trainee, you'll have what we call SDT time, which is your personal study time or self-development time. Sometimes some surgeries would put it in between your clinics, and other surgeries would actually give you half a day off. So again, it depends how they like to do it. It's usually better to take it off with your normal teaching GP days. But again, it's not a must. It depends on how the surgeries like to do it. Now, because this is an 80% rota, you're going to see that on Thursday you have a full day off. So this is your entitlement day, which is your day off. Again, it can be Friday, it can be Monday. It depends on the agreement that you have with your GP surgery. In between, in the middle of the week or somewhere in the week, you'll need to have your tutorial, which is usually 2 hours. So if you can see here on a Tuesday, there's a 2 hour slot for your tutorial time. And your tutorial time is the time where you sit with your educational or clinical supervisor and you either discuss cases, you discuss your portfolio, If you're approaching your exams, then you discuss certain stuff about the exam, and maybe have some role play for your SAA exam. So it depends how you use it. Some of these tutorial sessions are educational. For example, you don't really know much about contraception or HRT, so you discuss it with your supervisor. It depends how your supervisor has their own suggestions, or you have certain learning points that you want to talk about in these sessions. But the tutorial is usually in between your surgeries or at the beginning of your surgery. Again, it depends on each clinic and it depends on the agreement you have. Some people might have it at the very end, so after the afternoon clinic, they use the tutorial at the end of their clinic. Again, each rota is different, but what's set is that you have your morning and afternoon. You have your in-between time for your admin visits and lunch break. This is something that's set in every rota. When you have your personal study and when you have your tutorial is what roughly changes. Okay, so we're going to move on to what happens in induction. GP inductions are usually good. You get your regular induction. They take you through the building because it's a different setting than the hospital. So they'll need to show you around where's the storage area, where's the reception, where are the secretaries and things like that. Who to go to if you need to discuss any cases. For example, it's usually your educational clinical supervisor, but if they're not there, who to go to. They're going to give you a bit of shadowing, especially that the GP setting has different computer systems than the hospital. So you can't really go through a clinic on day one. If I would recommend, if your surgery is trying to do this, then try to ask them for a proper induction and shadowing period. Now, in these induction days, you usually get trained through the different system that you're using. So either EMIS System 1, they give you the induction. For EMIS, it usually happens online. For System 1, sometimes it is a mix of online or face-to-face. And now you need to also set up and get your smart card. So what is a smart card? If you can see here at the right side, it is your ID card in order to operate the system. So a smart card has like a tiny chip. You put it in the computer, and this is what opens your EMIS or your System 1 or whatever system your GP surgery is using. Now, also another thing that happens is that you get your equipments. Now, most of the time in a GP setting, you're given the equipments by the surgery. Some surgeries would ask you to get your own. A stethoscope is something that you have to have on your own, but other things that you're using, especially in your day-to-day use and in your home visits, are provided by the surgery. Some surgeries would want you to sign a list and put down a deposit in case any of them goes missing or get damaged, and some of them they just give it to you without any like insurance or any papers to sign. So that's the induction. And these are the equipments that you're usually given. Now, again, as I said before, the stethoscope is something that you need to have on your own, but the otoscope, the fundoscope, the pulse oximetry, and the blood pressure machine are not usually expected that every one of us has it before they start their GP placement. And because they're also like expensive equipment, as a GP trainee, you're not expected to have them to buy them on your own. If you want to go ahead and invest in them, you're going to need them eventually when you're like a fully qualified GP, then go ahead and do that. But at the start, you shouldn't be buying these stuff on your own. Okay, so these are the equipments that we use on a daily basis in a GP setting. Now, the dress code, it could be one of these three things. So semi-formal or smart casual, like as you can see in the picture, this GP is wearing, or you can actually wear your own scrubs. You can mix between them. So one day you can come wearing like a semi-formal, smart casual wear, and then another way you can be wearing scrubs, unless you're told otherwise. So if a surgery only wants you to wear, for example, semi-formal, or a surgery only wants you to wear scrubs, so unless you're told otherwise, you can mix and match. Now, what kind of support do you normally get in a GP setting? Now, a GP setting is well supported, although it's isolated, like you're on your own in the clinic, you're not on your own in the building. And there's always someone that you can go to ask certain questions if you don't know. Now, your supervisors, most of the time, are going to be there, either your clinical or educational supervisor. These are the people to discuss your daily cases with. The on-call GP is the person responsible for discussing cases if your supervisor is not available. Okay? And then you have your um, team. The rest of the team are your secretaries and your reception. Also, you're going to have the nurses, the PAs. Usually, if you have a specialist nurse like your diabetic hypertension nurse and you don't know certain stuff, you can again go and ask them. Now, your admin team, the secretaries and the reception, do two different jobs. The secretaries are the ones that help you with the referral and with your tasks. So if you get a referral that you're stuck in or certain tasks that you don't know how to do, I would say the person to go to is your secretary team. Your reception team are the ones that book your daily cases. If there's certain cases that you want to see, for example, let's say you don't know much about pediatrics and you want to get this experience, you can ask your reception team to book you in with a few pediatric cases. Now, this is common practice that we sometimes do when we're approaching the SCA exam and we need to practice in certain cases. Then we ask the reception team, for example, to book more women health, to book more elderly, to book more people with comorbidities. So you can actually ask the reception to book certain cases. Of course, ask your supervisor first and go through the plan with them, and then the team are usually cooperative and happy to help you with the things that you need. Okay, so this is the support that you get. And then you have your colleagues, of course, your other trainees, other GPs like the salaried and locum GPs. So usually a GP surgery is well staffed, and you'll always find someone if you need help. An important thing is if you need a chaperone, in some GP surgeries, the reception team are actually trained as chaperones. Okay, so if you need chaperones, some GP surgeries train the reception team or their secretary team, and you can ask them to be a chaperone if a medical professional is busy. Okay, so what are the computer systems that we normally use in a GP setting? The most common ones are these three: System 1, Vision 3, and EMIS. Okay, today I'm going to talk you through EMIS. So EMIS is one of the most common computer systems that we use in a GP setting. And if you can see here at the bottom left, this is how the EMIS web looks like. So this is the icon that you're going to use, you're going to press on. And as soon as you press on it, this is how it comes on. Now there's two ways to log into EMIS, either using your smart card or using your username and password. And usually the smart card is what we always do, unless you forgot it at home for some reason. The smart card is the fastest way to log in. So you just put your smart card into your computer. The picture on the left is what shows up. You put your passcode, which is usually a few numbers, about 6 numbers, and you just press OK and that's it. Now, when you press an EMIS and you don't have your smart card, you'll need to put your username and password and then log on. Now, the downfall if you don't have your smart card is that you cannot send the scripts. So when you're setting the prescriptions, the way we do it is that we do it through the smart card. When people forget their smart card, then they'll have to either print the prescription or ask someone else to do it for them. So it's very important to have your smart card with you all the time. Now, as soon as you open EMIS, this is how the dashboard looks like. You have different icons and different stuff there. We're going to go through them all, but the most important one, as soon as you open it, is your appointment book. Okay, so this icon right here, or you can also see it right here, is your appointment book, and this is where all your surgeries are and your patients are booked in. As soon as you press on the appointment book, whatever way you want to press it, from the launch menu or from the dashboard at the front right there, as soon as you press it, this is how it comes on. So again, you press on your appointment book, this is how it looks like. And this is a typical surgery for like a fully qualified GP, we do 10-minute slots. But for you as an ST1 or as a person who just started a GP, usually you're put on 30 minutes. So you see four patients per session. Okay? When you're a fully qualified GP, you'll see about 15 up to 18, sometimes 12 patients per session. Again, it differs what kind of practice you're working in, but that's the range from 12 to 18. I would say 18 is a bit too much, but it's not unheard of. So the average is about 15 patients. So, anyways, when you're starting, you're going to be put on 30 minutes. Usually it's a 30-minute appointment. Some GP surgeries would push you to start in 20 minutes right away. If you have no experience whatsoever in a GP setting, I would say try to ask them for a 30-minute slot at the beginning. Okay. In this part right here where you see face to face, you're going to see the patient's name. And in the part where you see reason, you're going to see the complaint. So, for example, Mr. Smith is booked in at 9 o'clock, coming in with abdominal pain. If there's any slot notes, sometimes the surgery or the reception will tell you, and please discuss their bloods. You would see it in the slot notes right there. Or please don't see this patient alone. Whatever notes they want to put on, they're going to put it in this section area. Okay. So let's say your patient has arrived. As soon as the patient arrives, you're going to see this A mark next to their name, and you would know that they have arrived. So either the reception are going to arrive them, or they can actually check in themselves. So when you see this mark, what you'll need to do is that you'll need to send the patient in. So the way you do it, you just click, right click, and go into change slot status and press send patient in. Okay, so this is one way of doing it. So again, you go into the patient's name. So I can see here my patient arrived at 10 past 2. I basically right clicked and put the patient in to send them in. Okay. There's another easier way to do it. You just press on the patient and you click S on your keyboard. Okay, so there's a lot of shortcuts that you can use on your keyboard that saves you time and it makes it easier for you to navigate through EMIS. So I would say the way I do it and the way I think every GP does it is they basically press on the patient, press S, and then basically the patient goes in. There's two ways that the patient goes in. Either the reception are going to ask them to go into your room, or you're going to go out and call the patient yourself. Going out and calling your patient yourself, I would say, is the more common practice. Okay? So the patient has arrived and the patient is now in your room. You'll need to start your consultation. And as soon as you press send patient in, this is how it looks like. So you'll have your date, your time, you'll have your name, the patient's name, and so on. Now, on the left side, as you can see right here, is the tools that you use in your consultation. And usually we all press on three things. We press on history, we press on examination, and then we press on comment. Okay? And this is how it looks like. History, examination, comment. And this is how we start our consultation. So you set up everything to be ready. Your patient is in your room. As soon as the patient is in your room, you press all these three options and you start your consultation. Now, if you want to read anything about a patient before sending them in, like you don't know if this patient has had previous history of, let's say, abdominal pain, then there's an icon called consultation right there. You press on it, and all the patient's history and previous consultation comes on. Okay, so if you want to have a bit of a read before sending your patients in, you definitely can go through their history. Now, sometimes when you're pressing on consultation and you're starting right here at the bottom, if you can see this dotted mark, if you push it upwards, you're going to see the previous consultations from the last few days. So there's a few ways to go through your patient's consultation. Have a read before sending a patient in, just to know a bit of a history about this patient. Okay, so your patient is in the room and you've started your consultation. Now, this is typically what we write in. We usually write presenting complaint. So let's say this patient's coming with back pain, abdominal pain, and then we write a bit of history. So let's say this pain started a few weeks ago. It's what makes it worse. It's worse when leaning forward. Again, what makes it better? You can write down better when resting, better when taking pain relief. You need to write your red flags. So there is no coda equina syndrome symptoms. There's no incontinence. There's no saddle anesthesia. Usually when you write no red flags, just identify what red flags are you talking about. So just don't write no red flags or no CES, and that's it. It's better for you to be more specific. Now, there's no history of trauma, no injuries. How is it affecting the patient's life? The patient is unable to sleep because of it. Okay, it's reported as a sharp pain, like being stabbed, for example. When you're quoting a patient's saying, like for example, the patient saying, "This is the worst pain in my life, this is the worst day in my life," just put it between quotation marks. For anyone who's reading knows this is the patient's word and not your own expression. Okay, so if taking a full history, we're going to write the examination, but I'll take you through how the examination is done. And then we write in the comments section, we write our impression or diagnosis. It doesn't have to be the exact diagnosis, it can be your differential. So I don't know if this patient has like an MSK pain or sciatica, I can write that. So in the impression, you just write, for example, I feel like this patient has sciatica. And what is my management plan? My management plan is I'm going to write, prescribe some pain relief. So what is the specific kind of pain relief? We're going to try this patient some amitriptyline, let's say, with some cocodamol. We're going to advise this patient to do physiotherapy, self-referral. And I'll explain to you why it's coming as self-referral in a few minutes, but this is my plan. Now, if there's anything more that you need to write in is your safety netting. So, for example, safety netted the patient, any CS symptoms to go to A&E immediately, for example. Okay, there's a lot of other things that you can write in your comment. Your comment is your plan in your management. For example, I've advised patients supportive treatment at home, like warm compressors, resting, mild exercises, so no heavy lifting. Patient asked for sick notes. All of this, you're going to write it in your comment section. So again, just to summarize, your comment section is your diagnosis and your management plan, which has your safety netting as well. And when exactly did you tell your patient to come back in if there's a follow-up? All this is written in your comment section. Now, if you've noticed, I don't know if you've attended our previous seminars, but if you've noticed, the consultation in a GP is quite different than a hospital. In what sense? We don't have like a very detailed history of presenting complaint. We don't have the patient's social. We're not writing the patient's medication. We're not writing the patient's family history, for example. Um, no, we do write the family history if it's relevant, but there's a lot of history that's missing. And if you ask why, it's because it's already in the system. There's no need to write the patient medication because the patient medication is already in the patient notes. You don't need to write the patient's previous past medical history because, again, it's in the notes. If the social has been written before, you're gonna see it in the patient list, unless you wanna like go through it again. For example, are you still a smoker? How much do you drink? All these stuff, all these information are already in the patient's notes. So you don't need to rewrite them. Unlike a hospital setting, you'll need to rewrite the patient past medical history, the patient medication, a lot of details, a bit of more details than the history that you take in a GP setting. And bear in mind that we only have 10 to 30 minutes per consultation with the patient. So that's why the consultation style in a GP setting is a bit more abbreviated than a hospital. A hospital, you can write paragraphs and paragraphs of history, and that's absolutely fine. Okay, so I'm going to take you through the examination bit because just to show you how you can actually do it. So on the EMIS system, whenever you write something, you're gonna find that it's actually integrated into the system. For let's say I'm taking the patient's temperature. So if you can see here, as soon as I write tympanic or even TYM, you're gonna see options down below to pick from. Let's say I'm taking the patient's temperature, so I'm gonna press on tympanic temperature, and this is how it comes up. And you're gonna write the numbers right here. You're gonna click enter or this green arrow right there, and it's going to be saved into the consultation. Again, let's say I'm taking the patient's pulse. As soon as you write pulse, you're going to find different options down below. Am I talking about the pulse rate? Am I talking about that the pulse is regular? Am I talking about different pulses that I've felt? So you're going to pick what you need, and it's going to look something like that. So most of these are actually already integrated into the system, like the tympanic temperature, the pulse, the blood pressure. And then there are things that you write yourself, like look swell, engaging in conversation, talking full sentences. All of these are things that I've written. But again, when you write ENT, it comes up as an option that you can click on, ENT, no abnormality. For example, breast examination, again, it comes down as a list of options that you can pick from. And let's say there's no abnormality, you can write it in. Another important part in examination that you please don't forget is your chaperone. So if you're doing any intimate examination, as soon as you write chaperone, you can have different options. For example, patient declined chaperone, you'll need to write the reason why. Chaperone present, you're gonna need to write their name. So make sure when you're having a chaperone to write them in. And I would say, please, as a trainee, if a patient is declining chaperone and it's an intimate examination, especially if it's the opposite gender, if you're uncomfortable, please do not examine the patient and try to explain to them why this is important for their safety and for your safety as well. Okay, so chaperone is very, very important. And again, you'll see different clinical and non-clinical staff that are trained to be chaperones. Okay, so this is how a typical examination would look like on an EMIS system. And then we're going to move up to other stuff that we're going to do. So you finish your consultation and you want to do investigations and, for example, let's say medication. So when you're picking certain investigations for the patient, you're going to go on test request. You're going to press on online test request. And then you're going to press your hospital. So because I'm in the Northwest, Lancashire Teaching Hospital is our hospital here in this area. You're going to press on the hospital that is assigned to your clinic, and then you're going to pick what kind of tests you need. And there are different kind of tests, blood, radiology, different kind of blood test. You can have your microbiology tests, which are your urine sample, your stool sample, your swabs. So there's a lot of options to pick from. And you just tick what you need. So you tick exactly what you need for this patient. You're going to write your reason, and then it comes something like that. So as soon as you tick your own bloods that you need, for example, for this patient, I've picked LFT, FBC, and UNE. I'll have to write the clinical details here. So why am I picking these bloods? Let's say monitoring. Or let's say patient's tired all the time. Whatever your reason is, most of the time, the sample to be collected later, you have to press on this. Okay, so you have to make sure that this is clicked on, and then you're gonna press on accept request. And the paper is gonna be printed out. You're gonna give it to your patient and you'll ask them to go to the blood clinic, or if you have the service in your GP surgeries, just tell them to book for the bloods with the reception. Okay? So it's very simple, very easy to use. If you're doing the same for the radiology, it's exactly the same. You press on radiology, you press on the certain investigation that you need. And again, you have to write your clinical reasoning and then accept request. Now, we're a bit limited to what kind of radiology we can pick. So a lot of MRIs and CTs, we cannot actually request them as a GP. And these are the things that you're going to be told in your induction. So the only MRI that we can actually book for our patients is an MRI knee. And it's limited to the kind of patient that we can book an MRI knee for. For example, any patient above the age of 60, we cannot book an MRI knee for them. It has to go through MSK or the orthopedic team. There's a few CTs that we can do, like the urgent ones, but a random CT, we can't really do it. So radiology is quite limited in a GP setting. So don't promise your patient a certain investigation unless you're actually able to book it for them. Okay, so we've done our investigations and we just want to prescribe the medications now. So again, right there, where we're picking all our history examination and so on, you're going to find medication. And as soon as you press your medications, this toolbox comes on. Now, right here is the name of the medication. Okay. As soon as you write the name of the medication, op certain options come on, like the doses, the form. Is it capsule? Is it tablets? Is it an oral solution? What exactly is the dose and form of the medication that you need it to be? You're gonna press on the different types and different doses that you want, and it comes something like that. So I've picked my medication. So right here, I was prescribing lansoprazole. I've told the patient how to take this medication, so one to be taken each morning. I've put the quantity, and I'm going to write a note for the patient. So in the right side right here, you can actually send certain information to the pharmacy or certain information to the patient. Let's say, for example, you want the pharmacy to make sure that they've told the patient a certain information. You just write it here. This is a one-off script. It's not for repeat. You write it right here. Now, for this patient, I've told them in the consultation, but I want it to be on their prescription as well. Please only start this after giving us this stool test, which is the H. pylori test. So don't start this medication unless you've given us the stool test. Okay? Another thing that comes on and is very important when you're prescribing your medications is the alarm. As soon as you press on a certain medication and it doesn't really align with the patient history, you're gonna get certain alarms coming on. Like for example, right here, you can see that the system is telling you this medication shouldn't be prescribed in moderate to severe hepatic impairment, which means that it might be a certain point that this patient's ALT or LFTs have been a bit off. So please check when any alarm comes on. Please check before going on and prescribing the medication. Other alarms that come on are the interactions. So if you're prescribing a certain medication that shouldn't be prescribed with another medication, a red alarm is going to come on. So again, please check. Please check your BNF. Please check that the patient is still on these medications. Sometimes these alarms are just from past medical history stuff, and the patient LAT is fine, or the patient's not taking this medication anymore. So double check before prescribing anything. You can see the drug information right here. So if you want to press on the and read a bit more about this medication, you can actually do that right here. You can check the patient current medication list right there, and the patient past medication, sorry, and their allergies. So you can actually navigate through their history before prescribing the medications. If you're happy with your prescription, just press accept and send it through to their pharmacy or print it off if they want it as a printed prescription. Okay, I hope this is clear. Again, this is quite easy to use and you're going to get used to it by time. So we're moving on to, I've finished my consultation and I want to refer this patient. So there's two ways, one way to do it, and there's two ways that we do our referrals. So we're gonna go through documents, we're gonna create a letter. Now our referrals can either be an automatic template that we fill in and we send it through to our secretaries to send it through to the hospital, or we're gonna actually write a letter. So as soon as you press on document and you press on create letter, this is how it looks like. So as you can see here, your 2-week rule templates, your ADHD, all of these are templates that you fill in. So they're automatic tick boxing that you do, and then you write a bit of history and you send it, and that's it. Now, if there isn't a certain template for the service that you're referring to, so your normal referrals like neurology, endocrine, gastro, all these stuff are usually a letter that you write. You'll either dictate it if you have these mics in your GP setting, or you're gonna write it for your secretaries. Okay, so if you're gonna write a letter yourself, there's something called create letter, or acute letter, or referral letter, whatever kind of naming that your surgery has. It might be different from one surgery to another, but as soon as you press on it, this is how it shows up. Okay, so you're gonna start your letter by addressing the department that you're sending them to, or for example, let's say this patient is known to a certain consultant, then you're gonna write, "Dear Mr. or Doctor, whoever, I would appreciate you seeing this patient, or I'm kindly referring this patient for 1, 2, 3." And you're going to write your history. You're going to write the reason why you're referring this patient. And for example, if you have something in mind that you want them to do, you're going to write it. For example, when we're referring to ortho, in order for them just to book an MRI, we're going to say that this patient has knee locking, giving way, pain that's affecting their daily activity, and we believe that they would benefit from a knee MRI to rule out a meniscal tear. So just write what you want and send the referral through. When we're sending the referral through, we'll need to task it to our secretaries. So we can see right here an icon called Add Task. You're going to find it in your consultation. So as soon as you press on Add Task, you're going to find this pops up and you're going to see what kind of task you need. So there are different tasks. Sometimes you're just sending a note to the admin, to the reception. But in there, when you press on there, sorry, you're going to see a referral. And when you press on referral, you'll have to task it to who you're sending it to. It's usually the secretaries. So again, in the search button, you're just going to press on secretaries, and then you're going to write what you need. For example, please refer under 2-week rule. Please refer to gastro, and you'll have to put in the urgency. Please, any 2-week rule referrals, click on the urgent button right here, and then send it through. If it's a non-urgent referral, then just write it as normal and send it through. Okay? If you're referring the patient to hospital the same day, this is a completely different story. You're going to need to pick up the phone and refer the patient. But if it's something that you just need a clinic appointment for it, this is how we do it. Okay? Let's say this patient doesn't need to be seen in the hospital the same day. You need to refer this patient. But of course, as we're all aware, the waiting time in the NHS can be a bit too much. And you need someone to give you a certain plan or a certain diagnosis in the next couple of days. But this patient is not acutely unwell to send them to the hospital. What should you do? Apart from discussing with your supervisor, which is one of the solutions. Another thing that's really good that we use almost on a daily basis in a GP setting is a service called advice and guidance. So advice and guidance is a messaging system between you and secondary care. And you can ask like the consultants or senior registrars about certain cases. So when you press on advice and guidance right here, you can click which department you want to speak to. So let's say I want to talk to acute medicine, cardiology, and then you'll write your message right here. For example, to dear colleague, this patient has been presenting with chest pain. It's not a typical MI, and it's not really aligning up with angina. I'm going to write the medication. For example, this patient is taking bisoprolol, ramipril, so on and so on, and we feel like we've exhausted all our medication options. What would you recommend next step? For example. One that we use very commonly is the dermatology because you can actually send pictures. So if you can see right here, if you press on dermatology, you can attach certain pictures to them and send it through. And it's really, really good because sometimes you don't really know what kind of rash you're dealing with. Well, let's say you've tried all the creams and all the management that you can do, but this rash is resistant to any treatment. The wait for dermatology might take up to 8-9 months until they're seen. So you don't really want your patient to suffer for 9 months continuously. So you can actually send through the pictures to dermatology. And just send it through. The replies usually comes onto your personal email. So your nhs.uk email that you've used to register to EMIS and that you've got it from your practice as soon as you start your GP placement, this is the one that you get your advice and guidance messaging back to. So make sure to open your email every single day to check if there's any replies that are coming back, okay? Now, we're coming to the end of our consultation, so we've done all this to the patient. There's two options really. Save the consultation, okay? Or move on to the next problem. So let's say this patient is coming in with two things. Then you need to press next problem and just write it in. Now, usually the rule is in every single surgery, it's one problem per patient. But if you're someone who's on 30 minutes, I would say doing two problems is not an issue. However, if you feel it's too much for you, especially if you're starting, you're new to the NHS, then you can simply say no. You can simply say to the patient, I'm sorry, but this is only one problem per consultation. Please book another appointment. However, be very careful when you're doing that because it depends on what kind of problem they're coming in with. So if the patient was talking about hair fall and then their next problem is chest pain, then this can be a bit tricky. So at the beginning of your consultation, usually what we ask patients, what are you coming here with? For example, let's say they've told you hair fall. Is there something else that's bothering you today? Yes, chest pain. Okay, I feel like chest pain is something more important for us to discuss. So let's go through chest pain and let's see if we have enough time to discuss your hair fall at the end. Okay, so it is a skills that you need for your consultation. There's a certain way to do consultations in a GP setting in order to be safe and make sure that you're covering your patient's need as much as possible. But we're going to discuss this in a different video, hopefully soon. Okay, so I've saved my consultation and I want to message the patient. There's a few reasons why you need to message your patient. Um, I don't know if you remember at the beginning of the consultation, sorry, of this video, when I told you about physiotherapy self-referral. There are certain things that the patient refers themselves to them, certain services. Physiotherapy is one of them. Mental health is another one, which is Minds Matter. So you can actually message your patient. Accurix is what we use. So this is their icon right there. And when you press on it, this comes on. Okay. And if you press on this icon right here, the new message comes on. Usually, if you pick your patient on EMIS, their name automatically comes here. And then you check your templates, you search your templates. So if I write physiotherapy, the physiotherapy self-referral link is going to come on, and an automated message is going to be right here. And you just press send. Let's say this patient, you're having a telephone consultation or a face-to-face consultation with someone with a rash, and you want them to send you the photos before you see them. This makes your consultation better or faster. So you just press on photo and then photo for upcoming telephone appointments, send photo, take a photo, whatever you want. And when you're pressing photos, just make sure allow reply is on, because if you're sending this link without allow reply, they're not going to be able to send the photos through. You can message your patient for multiple reasons: to remind them of certain appointments coming on, to tell them to do certain blood tests. If you've forgotten a certain recommendation, a certain thing to tell them about medication, for example, or their appointments, you can message them. You can simply just send the message. Make sure that the number is correct. And this is the person that you're sending the message to. Okay, you don't want to be sending random messages to different patients. So again, this is your toolbar that you can see as soon as you open EMIS. And as soon as you open a certain consultation for a patient or click on a patient, this comes on. So your consultations are the previous consultations that the patient had. Medications are the medication list for the patient. Problems is the past medical history. Investigations is where you have all the bloods, radiology, swabs, and also the patient weight, height, BMI, so on, are in investigations. Usually we go through all these when we're quickly like reading before seeing a patient. And then your documents is where you'll see the hospital letters. Okay, diary is the patient's appointment book. We don't really use it much unless you want to see if this patient is booked for a follow-up or what time the patient's coming in, so on. But our daily things that we use is consultation, medication, problems, investigations, and the documents. It's very easy to navigate through EMIS, and it's also easy to navigate through System 1. And by time, you're going to get used to it. I would say in the first week, you're going to get the hold of it and you're going to know how to use it. And as you go on along your like rotation, you're going to learn more and more about things to do. Now, just before we finish here, two things really that I want to talk about. When you see this toolbar right there, down there, is where you get your tasks. So anything that the secretaries, the reception, certain doctors need from you, you're going to find it right here. And the red is how many tasks you have. So right here, I had one task to do. So you press on it and you have to check it every single day. So this is where your admin work comes on. So your admin work is your tasks, your lab reports, anything that you've booked for a patient, bloods, radiology, it comes under lab report and you have to action them. Okay? These are the two main things that we use as a GP trainees. When you're becoming a fully qualified GP or you're an ST3, you might be using the medicine management, which is the prescription, and you'll be going through documents and referrals and so on. But the main thing that you need to focus on, which is your admin work that's expected from you, is the lab reports and tasks, unless you're told otherwise in your induction. Okay, so an important thing in a GP setting is the home visits. And home visits, you might be expected to do them on a daily basis. And unfortunately, on a home visit, a lot of you are asking, do we get someone to go with us? The answer is no. Home visits are usually done alone. When you're doing the induction week or days that you get offered by your GP practice, you're gonna go with one of the GP partners or with one of the more senior trainees on home visits to learn how it's done. So it's important to have a car in when you're doing your GP placement. I would say it can be doable with a bus, but it will waste time. So I would honestly recommend getting a car before you start your GP placement, because the home visits can be as far as like 20-minute drive, or it can be just a 5-minute drive, which could be like a 10-minute walk. So in your home visits, it's normal cases that you see on a daily basis, but the patient, for example, is homebound or quite unwell to go out, so you go and see them yourself. If you feel that a certain patient has a lot alarms that this patient is not very safe to see, you're gonna see it before going to the patient. And then I would say if you're not comfortable, take someone with you. Otherwise, usually home visits are quite safe and it's easily doable on your own. There isn't a certain time slot for home visits. Home visits can take from, I would say, 15-20 minutes up to like 40 minutes. So it depends how long the drive is. It depends what you go to. So what kind of case are you dealing with? Are you expected to do home visits as a trainee? Yes, definitely. You'll be expected to do home visits as a trainee. It depends how busy your practice is. You can get daily home visits, or you can get just once or twice weekly home visits. Okay, so we're coming to the very end, and we're just going to go through common cases. So you have your infections that you see on a daily basis: chest, UTIs, otitis media, cellulitis. It's both in adults and pediatrics. You have your typical tired all the time patients that come in. You have your skin rashes that can be eczema, tinea, psoriasis. It can be things that you've never seen before and you have no idea what they are. So please always ask. Then you'll get your MSK stuff like the back pain, knee pain, shoulder pain, carpal tunnel, sciatica, so on. Women's health is something that you're going to see on a daily basis. So you have your patients that are coming in with irregular period, heavy bleeding, menopause, vaginal infection, breast lumps, infertility, women that are traveling and want to stop their periods. So all these you see in under women's health. Long-term conditions, diabetes, hypertension, thyroid, COPD, asthma, so on. Mental health is a very big one in GP. So you have your anxiety, depression, PTSD, addiction. You're not expected to do therapy in a GP setting. You're just doing the management part, or I would say the initial management part. If this patient has personality disorders or psychosis, they're usually under the psychiatry team. Safeguarding cases, of course, we see them a lot. And by the time you finish your GP training, you should be able to pick safeguarding cases easily, because patients are not going to come in and tell you I'm a safeguarding case. You'll have to pick up the cues and be able to tell if this case needs to go under safeguarding or not. Memory issues, again, is a big one. Patients coming in because they're concerned about their memory, or patients coming in with the relative because they're worried about their memory. Certain things like abdominal pain, that you have your gastritis, your IBD, your IBS, and your colon cancers. So all of these are just, a summary of the cases that you see. Again, you'll have your patients that want to lose weight and patients that actually want to gain weight. Especially in pediatrics, you're going to get a lot of parents that are not very happy about their child's weight and they feel like they're not eating very well or they're picky eaters. So you're going to get this a lot in a GP setting. The most important thing is if you don't know, please ask. We've come to the end of our video. If you've enjoyed this video and you want to watch the other upcoming ones for GP, then please subscribe and like and comment below if you have any suggestions about other videos that you want us to do. And these are our pages if you want to join us. And hopefully I'll see you again in the next video. Thank you so much for watching.